Good afternoon, and thank you for joining the RLS Foundation's webinar titled RLS Opioid Registry Update. My name is Zibby Crawford, and I'm the Membership and Marketing Coordinator of the RLS Foundation. Before we begin, please be sure that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Winkleman will answer as many questions as time allows at the conclusion of his presentation. The surge in the use of web-based programs during the COVID-19 health crisis has created strain on the system. If you're experiencing technical difficulty, switch to audio with the telephone number listed on your invitation, as it uses less bandwidth. We thank you for attending and appreciate your patience and understanding during today's webinar presentation. After the webinar, you will receive an email with a link to the webinar recording. The recording will also be made available in the member portal section of our website. If you're not a Foundation member, and if you'd like to view this and all other recorded webinars, we invite you to become a member today. In celebration of our upcoming 30th anniversary, you may join or renew your membership for only $30 by going to www.rls.org/30YRS until June 17th. As always, individuals suspecting they may have RLS should consult a qualified healthcare provider. Information provided in this webinar is for informational purposes only and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. John Winkleman. Dr. Winkleman is Chief of the Sleep Disorders Clinic Research Program, Department of Psychiatry at Massachusetts General Hospital, a certified RLS quality care center in Boston, Massachusetts. Dr. Winkleman received his PhD from Harvard University in psychobiology and his MD from Harvard Medical School. He finished a residency in psychiatry and a fellowship in neurology, sleep disorders medicine, at Massachusetts General Hospital. He has served as chairman of several national organizations, including the Nosology Committee, the Movement Disorders section of the American Academy of Sleep Medicine, and the American Academy of Neurology guideline committees for the treatment of RLS. Since 2000, he has served on the Foundation's Scientific and Medical Advisory Board. Dr. Winkleman's research interests include sleep-related movement disorders, insomnia, parasomnias. He is a leading expert in the field of RLS and has published many textbooks and authored over 100 articles in the field of sleep medicine. Dr. Winkleman, we thank you for sharing your time and your expertise with us today, and I invite you to begin your presentation.
Thank you, Zibby, and welcome everyone, and thank you for listening to this presentation today. I'm going to try to move through it at a decent pace so that there's enough time for questions afterwards. And if you do have questions about any of the information in the talk, write them down so that you can ask them at the very end. And there we go. So usually people have their thank yous at the very, very end. Oftentimes I'm so rushed and tired and everything that I rush through these. So I thought I'd put it here at the beginning. I want to thank the participants of the National RLS Opioid Registry for the time that they put in filling out the surveys every 6 months, and for the time that they originally gave when we did our original interviews. Thank you to all of you, if there are any of you in the audience today. I also want to thank the RLS Foundation, who has funded the registry from the beginning and continues to fund part of its work. This started off with a kind of a crazy idea that I had that this would be valuable, and thanks to the participants, it really, I think, has been of value. I want to also thank the Bazooki Brain Research Fund, who is funding my research, as well as a number of families and family foundations for their support of this work. So let's see what we're going to talk about today. We're going to do a very quick overview of RLS treatment. You've heard about this from other speakers, so I don't need to belabor it. Then we'll talk about the RLS registry data update, information about the participants at baseline, and now information of roughly 450 people who have completed 2 years in the registry. Roughly, just so that you know, about a quarter of the participants, 150 almost, have completed 4 years in the registry. So we're not babies anymore in this registry, and we're growing up, and the longer that it is maintained, the better the information that we have. Then we're going to talk about what's next, and then there'll be questions. So a little bit of background. What I say to patients when I'm talking to them is we have 4 proven classes of medications for restless leg syndrome: the dopamine agonists, the alpha-2 delta ligands, A2Ds as they're sometimes called. This would be gabapentin, pregabalin, that's Neurontin and Lyrica, and gabapentin enacarbil, which is Horizont. The third class of treatments, medication treatments, if you will, are iron treatments, and the fourth class are opioids, and we'll be talking about that fourth class predominantly today. As you are aware, I'm sure, dopamine agonists are extremely effective in the short term, but over a number of years, for many people, they don't work as well, and in fact, start to make the restless legs worse. And as you can see in this graphic to the right, worsening of RLS due to augmentation leads healthcare practitioners to increase the doses of the dopamine agonists, the DA doses, which then over time worsens augmentation, and round and round and round you go. These dopamine agonists are seductive medications because they work so well at the beginning. And what I say to people is I liken it to a relationship. And at the beginning, there's the honeymoon period and everything's going swimmingly. But sometimes, unfortunately, in relationships, one participant, one member can become abusive to another member. But the other member then oftentimes has difficulty getting out of the relationship for a variety of reasons. And for many people taking dopamine agonists, they become abusive medications over time. So we recently did a study looking at drug utilization for restless legs in the United States. This was 670,000 people in the US prescribed medications for RLS, 400,000 of them taking dopamine agonists. And we looked at the doses that the dopamine agonists that people were taking. And roughly 20% of all RLS patients in the United States, there's about 75,000 people, are prescribed dopamine agonists that are above what the FDA recommends as the maximum dose. Those maximum doses are ropinirole, Requip 4 milligrams, retigatin, Nupro 3 milligrams, and pramipexole. We actually allowed it to be 0.75 milligrams. The FDA says 0.5 milligrams should be the maximum. And in fact, half of these people at these elevated doses, so that's 10% of all RLS patients, were taking more than 50% more than the maximum dose, more than 6 milligrams of ropinirole, 4.5 milligrams of retigatin, or 1.25 milligrams of pramipexole. So these are people who are certainly augmented, although there are clearly people at acceptable doses, not above the maximum, who are also augmented. So let's now switch to discussion about opioids. On the left here, you can see what the guidance is that we developed for the RLS treatment guidelines. So opioids should be considered in those individuals who don't tolerate first-line approaches, the dopamine agonists, gabapentin, pregabalin, or iron. They have side effects at doses that would work. Or in people who do not have improvement if you, in their RLS, satisfactory improvement, if you manage things like replacing iron or stopping an antidepressant or treating sleep apnea. And they should also be considered in people with augmentation that don't respond to other approaches like iron or like gabapentin or pregabalin. And over on the right, you can just see the best study, controlled study of an opioid for restless leg syndrome. This was published almost 10 years ago now. And you can see that over time, the red line is below the blue line, red line being prolonged release oxycodone, the blue line being placebo. And you can see that over a period of 12 weeks, the oxycodone consistently beat the placebo. Opioids work for RLS. The other thing to keep in mind, and many of you may have experienced this, is that even though they work for RLS, fear gets in the way of opioid treatment. And it's not just fear from patients about taking these medications, which I understand because they certainly have a lot of stigma about them and they sound kind of scary if you, because there are certainly a lot of people in the US who are dying as a result of opioid overdoses, but it's also fear from doctors' perspective. And here we can see the prescriptions for opioids over a 20+ year period. And you can see that in 1992, in the far left, we were at about 43 prescriptions per, can't even remember what this is. Anyway, you can see that there's about 100 million estimated dispensed prescriptions in the United States for opioids. And then by 2010, this had doubled to between 80 and 85, or let's say about 175 million prescriptions. By 2020, this had dramatically reduced back to even lower than what it was in 1992. Doctors are afraid to write prescriptions for opioids. Some of this pullback in opioid prescription writing is most of it, in fact, is wise. Too many opioid prescriptions were being written. When I had my knee fixed, I got 60 oxycodone when I left, picked up at the pharmacy. I didn't even need a single one of them, but I got 60 of them. Now doctors are being educated not to give opioids unless they're necessary. Unfortunately, many doctors are taking this as a message not to prescribe opioids at all for anything. And this is where people suffer. And those of us in RLS, sometimes it feels like we're a fish swimming the wrong direction. Everyone else is stopping prescribing opioids, and we still are prescribing opioids, albeit at very low doses, and in very carefully screened patients, but we are doing something that is unusual. So let's talk about the registry data. As I said, this was an idea that I had to understand whether opioids can continue to be effective and safe over the long term in individuals who are using them for RLS. So originally, I asked the RLS Foundation for enough money to enroll 200 people. And we advertised it in a variety of places. And I talked to my colleagues at quality care centers and said, give your patients this email address, phone number, and contact us. And the response was overwhelming. So we were able to enroll 500 people. And we stopped at that point. We could have continued enrolling, but we only had a certain amount of time to do this. And these 500 individuals are ages 24 through 90. All of them needed to have had a previous good response to a dopamine agonist, kind of showing us that they had the quote unquote normal kind of restless leg syndrome. And they had to be taking daily opioids for RLS. We interviewed them quite extensively at that initial time and when they enrolled in the registry, just to make sure, of course, that they had RLS and to learn a lot about these folks. And 50%, 57% were female, which kind of represents the overall sex ratio of RLS, which is about 60% women. We have an older population in the registry, almost 3/4 or more than 60. 98% of the participants are white, which does not reflect the diversity of the United States, but may in fact reflect the population at whole of RLS sufferers, which is a genetic disorder and affects Caucasians more than other races. And the average body mass index was 28, so this was generally an overweight group of individuals. 61% had a family history of restless legs, and consistent with what has been published in the literature, over 40% had a history of depression, over 30% had a history of an anxiety disorder, almost 1/4 had a history of suicidal thoughts. And when we administered what's called the opioid risk tool to assess people's risk of misusing or abusing opioids, more than 3/4 had a low risk of opioid misuse or abuse. And here you see on the left, we have transformed the milligrams for opioids into what's called a morphine milligram equivalent. And I'm not going to bore you to death with the details of this, but this is a way to have an even playing ground for oxycodone and hydrocodone and methadone and buprenorphine, so that we kind of know the relative amount of opioid that people are taking, even though they're taking different opioids. And so the median was 30 MME, so that would be 20 milligrams of oxycodone or 7.5 milligrams of methadone. Over 3/4 of individuals take doses that are less than what is considered an elevated dose, and about 1 in 6 reported having severe or very severe RLS symptoms, even though they were on the opioid. And here you see a histogram of the distribution of doses of the opioids in MME, and you can see the median dose of methadone was 10 milligrams. The median dose of oxycodone was also 10 milligrams. That is, half the people taking methadone were above 10 milligrams, half were below 10 milligrams. Here, when we look at this pie chart, you can see there's this big blue area on the right, and over 50% of individuals were in the registry were taking methadone. So roughly 50%, about a quarter were taking oxycodone, and the next highest were hydrocodone, which is Vicodin, about 1 in 8 people. And now we look at the medication changes from baseline to 2 years. We now, out of the 500, were able to get information at 2 years on just about 450 people. You'll see that about 50 people over that time either stopped taking an opioid, were lost to follow-up, some people died, and so that leaves us with about 400, left us with about 450 at 2 years. Over 80% were taking the same opioid as at baseline. A very small percentage of people either added a dose of an opioid to their existing opioid or stopped taking an additional dose of it. About 1 in 8 people added a dopamine agonist or an alpha-2 delta, that's gabapentin or pregabalin, and about 10% removed one of those medications while they were taking the opioid. And about 1 in 7 people switched from one opioid to another opioid. And of the people who switched opioids, almost half switched to methadone. So this seems to be the direction that people are going. As you saw, 50% are taking methadone, and people who are switching from one opioid to another are switching to methadone. So very busy table here. I don't want to bore you with all of the details. The bottom line here in red is that there was no change in the median opioid dose from baseline to 2 years. At baseline, the median methadone dose was 10 milligrams, and at 2 years it was 10 milligrams. Oxycodone, baseline median was 10 milligrams, at 2 years was also 10 milligrams. These are medians, not means. So people who are taking higher doses make the means higher, although the median is not reflected. These higher doses are not reflected in the median. But bottom line, in the 450 participants at 2 years, there was no change in the median dose. So almost half of people, 43%, remained on the same dose. 41% did increase their dose, and we'll see in the next slide how much they increased it. And about 15% of people decreased their dose. So there's some variability in what happened with people's doses. So as I said before, looking at red here, no change in the median opioid dose from baseline to year 2. The median dose change for those who did increase, remember there was 40% of people did increase their opioid. The median dose increase was 10 MME, and 10 MME is 2.5 milligrams of oxycodone increase. I'm sorry, 2.5 milligrams of methadone increase and 6.6 milligrams of oxycodone increase. And for those who love the data, you can see here the distribution. Again, this is MME, which is less useful to you because you know milligrams, you don't know MME. At baseline, at year 2 on the left, and the changes from baseline to year 2 on the right. If we just look to the right figure, you can see that the vast majority, the biggest group, were people who did not change their dose of opioid, over 40%. But then when we look over to the right, you can see the next biggest are people who have this small change in opioid dose over these 2 years, less than 10 MME. Again, that's 2.5 milligrams increase of methadone, 6.6 of oxycodone. So the most common increase in people who do increase are very small. So our question is, who's most likely to increase their opioid dose? And in particular, who's most likely to increase their opioid dose by a fair amount? Here it says on the slide, large dose increases. It's not exactly clear what word we should use here, but they're, let's call them significant dose increases over these 2 years. So this is 25 MME increase. That's a methadone dose change of 6 milligrams. And an oxycodone dose of 16 milligrams. So you might think these are relatively large dose increases. Who's most likely to have an increase like that? And these 5 things here in the bullets account for everybody who had such an increase except one person. So if you don't have any of these 5 things, you basically have no risk of increasing your opioid over those 2 years. And those were people who switched opioid medications, most commonly, as we saw, from oxycodone to methadone, people who stopped a dopamine agonist or gabapentin or pregabalin. Makes sense because those medicines were helping the RLS, so the opioid has to help a little bit more. People with significant sleep disturbance at baseline, people who still had significant insomnia, people who had a history of major depression, and people who used opioids for another pain disorder, like low back pain or some other problem requiring opioids. And here you see how the distribution of RLS severity. And again, I'm not going to belabor this, but you can see in the right column here, in the right figure here, that most people had small changes in RLS severity, either increased or decreased. And the number of people who had worsened RLS was almost exactly the same as the people who had decreased IRLS or severity scores. So some people are getting better, some people are getting worse. But in general, most people, and it's almost 50%, have mild RLS, although about 1 in 5 have moderate, about 1 in 5 have severe, and only a very, very few people have very severe symptoms while on the opioid. You know, just to save time here, I'm just going to emphasize that there was no change in insomnia severity from baseline to 2 years. There was no change in depression severity in baseline to 2 years. And there was basically no change in anxiety severity from baseline to 2 years. So using the opioid did not seem to worsen any of these psychological or psychiatric symptoms. I do want to emphasize that when people entered the registry, they were not newly on the opioid. The most common amount of time that people had been on opioids when they entered the registry at enrollment was 1 to 3 years, but we had many people who had been on the opioid for more than 3 years. So we didn't get people right at the beginning. We got them somewhere kind of towards the beginning of their using opioids for RLS, and the idea was to follow them over time. And an important issue that many people with opioids face is stigma. And so we have asked this question at various time points. How worried are you about opioid regulations and your ability to continue receiving your opioid prescription. 75% of people in the registry said they were at least moderately worried, which is why I'm doing this work. People shouldn't have to be worried about getting prescribed medications for a medical disorder which has significant effects on quality of life. And I got this email very recently from somebody in the registry, and I thought I would just share the text with you. Let's see if I can read it. Part of it's covered up, unfortunately, by the thing here. Here we go. It says, Dr. Winkleman, I would love to become a participant again in the opioid registry study. We asked people who were no longer in the registry, who'd stopped opioids, why they had stopped them. She said, however, the last 2 sleep doctors have refused to give me opioids and insisted I take other medications which do not work as well. I now live in Arizona and can't find any provider who will help. I also suffer from severe arthritis in my back and several joints and find it almost cruel to deny an 84-year-old woman pain relief. This was very moving to me and was disturbing. So we asked other questions about stigma, and you can see here that about 1/3 of people said, I avoid telling people I receive opioid treatment for my RLS. A smaller percentage of people, maybe 10%, said they feel alone because of opioid treatment. About 1 in 4 people said sometimes I feel I'm being talked down to because my opioid treatment. I hear this a lot from patients who go to the pharmacy and they get the hairy eyeball from the pharmacist. And about 1 in 4 people said they've been discriminated against by professionals because of opioid treatment. I thought it would also be of some value to look at side effects that people are having from the opioids. About 1/2 of people at both baseline and 2 years were having constipation. About 1/4 had fatigue. 1 in 5 had itching, and about 1 in 6 had sweating. So let's reach some conclusions from this 2-year data that we have. Remember, we're going to continue to analyze the information we're getting from participants. As I said, we have about 1/4 of the whole registry population who is now at 4 years after their initial enrollment. But from the 2-year conclusions, we can say that prescribed opioids can control RLS symptoms over time, at least at 2 years, with minimal dose escalation. That the severity of RLS in the overall group was unchanged and continued to be in the low to moderate symptom range. And the 2 most common reasons that people had for discontinuing opioids, people who were on opioids when they enrolled in the registry and now are no longer on opioids, were 1, side effects, and 2, unwillingness of the prescriber to continue the opioid treatment, as we saw in that quote earlier. So where do we go from here? And as Jordana Zakin, who made these slides, these really lovely, lovely slides, and also made the logo for the National Opioid RLS Registry, which you may have seen at the beginning. She said, let's keep going. And in fact, that's our motto here. Let's just keep collecting information from people taking opioids and RLS. We want to do this to improve our understanding of the safety and tolerability of opioids, understand whether opioids will continue to be beneficial over the long term for RLS, and help in identifying those individual RLS patients who increase their dose substantially, why they're increasing their dose, what the risk factors might be for people who no longer get benefit from opioids. And for anybody in the audience who is in the registry, I want to thank you for your time. I know it takes about a half an hour each time to fill out the survey every 6 months. And I know you've got busy lives, but thank you very much for doing that. As you can see here, we've got the progress to date. And the light blue at the top are, I don't know if you can see my pointer here, but we had 500 people at the beginning. At 6 months, we were down to 480 because we had 8 people stop opioids, 5 people were lost to follow-up. Then here at 1 year, we were down to 467. We had some other people stopping opioids. At 1.5 years, down to 460. And the 2-year survey, we had 458. As you can see, we lost 8, 10, 15. We lost 15 people to follow up. I'm not sure they stopped responding to us. We had 4 people die. About 20 people stopped opioids for various reasons. And here you can see is the data we're continuing to collect. We're almost done with almost everybody has completed their 2.5-year survey. And as I said, we have 165 people now who have completed their 4-year survey. And we're hoping that we can get every single person who continues on opioids to fill out those surveys at 4 years. Before I finish and start with questions, I do want to say that we are doing a new study, and this is in people who have restless leg syndrome that is well treated, has to be well controlled RLS, but they continue to have insomnia. And I see this frequently in my patients. They say, boy, my legs are really good, but I lay down to go to sleep at night and I just can't fall asleep. Maybe it's because of all those years when I suffered with the RLS and I'm worried that I'm going to have RLS and I got into a habit of not sleeping, or people who wake up in the middle of the night who can't fall back asleep. So this is for people with well-controlled restless leg syndrome, but continue to have insomnia. We're investigating whether a specific FDA-approved sleeping medication called suvorexant or Belsomra can improve sleep in those individuals. Now note, I can only enroll people in this study who live in New England or California. Those are the only places I have a medical license. So I can't be sending medicines to people who live in states where I don't have a medical license. But otherwise, we'd love to hear from anybody who meets these criteria. Jordana's phone number is down there at the bottom. She's a lovely person, would love to hear from you. She does a brief interview on the phone to see whether it's a good match for you. And if it is, maybe we could help with your insomnia. On that note, let's see if there are any questions.
Great. So these are questions that were submitted before the webinar. A pain doctor recently told me that methadone is about to be banned in the US by the FDA. Is there any truth to this?
Not true. I mean, it's not true at all. Not even close to being true.
Right.
Methadone is a valuable tool in our ability to assist people with opioid use disorder. And as you know, opioid use disorder is unfortunately rampant in the United States. And there are really 2 opioids that are used for opioid use disorder to prevent people from withdrawing and therefore going and doing the things that they need to do to get to prevent withdrawal, it's methadone and buprenorphine. So certainly the government will not interfere with access to one of the two treatments for people with opioid use disorder. And of course, to note, people with RLS who use methadone use it at about 1/10 the dose that people with opioid use disorder use it. So I would go back to that pain doctor, and I'd be happy to hear from them and explain to them that this is not going to happen.
Thank you. Are opioids the last choice of treatment for RLS? What if opioids don't agree with you?
Yeah, opioids are really for, as I explained on one of my slides, people that don't respond or can't tolerate other approaches. So it is kind of the last line of treatment. The good news is that if one opioid doesn't work or you have side effects from it, I just try another opioid. And if that one doesn't work, I try another opioid. So they're not all the same. And so you just have to persevere and keep trying different opioid agents to see if they work and are better tolerated than the ones that failed previously.
Are you getting more insights about side effects? For example, how debilitating, how to offset them, and were they the reason to discontinue?
Yeah, it's an interesting question. I think that I hope that I addressed that at what the most common side effects are, which are constipation and sleepiness. But people also can have problems with itching, nausea, and sweating. Those would be kind of the most common other ones. And there are generally methods to address those side effects, either by switching opioids or by using some approach that counteracts the side effect.
All right. Do opioids lose effectiveness and require stopping and restarting?
Our experience has been that that is not true. As you saw, the majority of people, the most common thing is for people not to increase their dose. About 40%, at least in the first 2 years, do increase the dose, but they only increase it by a very small amount. I have not had people who have had to continuously increase the dose, and therefore I have had to stop it. That has not been my experience. Small dose increases, yes, but not continuous dose increases. So it certainly can occur, but I would say that it is rare.
What is the most surprising result of the study?
The most surprising result really is just how committed the participants are to this process. I have to say, I've really been touched and feel like this community really wants to get answers to this question about opioids and RLS and wants to make sure that opioids can continue to be available to them and to others like them who suffer with RLS, who have had augmentation from a dopamine agonist, don't tolerate gabapentin or Lyrica. So that persistence, people's willingness to fill out the surveys has really been surprising, and how many people we got who were interested in joining the registry was just overwhelmed us. As I said, we were hoping for 200, and we got 500 in the first year and a half and had to say, whoa, we don't have the time, money, capacity to continue to enroll people in the registry. In terms of the data, what's been the most surprising? I think that I have been surprised that people do increase their doses over the 2 years, but I've been reassured that when those dose increases have occurred, they're generally very small. And if they're not very small, that we can find factors that seem to predict who is going to need to increase their dose more than a small amount.
All right. And I know the answer, but I'm going to make sure everyone knows. Does the registry accept new participants?
Unfortunately not. As I said before,
Yeah.
we got to 500 and we said, this is extraordinary, amazing, but we had to stop. So we stopped at 500.
Right. How are the results from this registry being used to influence opioid policies at the federal level?
Well, the RLS Foundation has lobbying efforts in Washington, and I think I've been to Washington, I think it was twice. I can't remember, with Carla and Zibby. It was kind of fun and kind of scary walking into the Capitol and the Senate chambers or whatever they are, and meeting with all of these legislators and talking to them about restless leg syndrome, letting them know that opioids are a really effective treatment and that opioid regulations were potentially, and in fact, in many cases, actually interfering with people getting an effective treatment. As we saw, even sleep doctors being unwilling to prescribe opioids, and many, many other doctors just saying, oh no, I don't prescribe those medicines, which is, I think, truly unfortunate. So we're trying to bring some rationality into the discussion about opioids at a national level. We've got a terrible problem with opioid use disorder and overdose deaths. However, if you carefully screen people with restless leg syndrome, you can almost completely, if not completely, avoid those problems.
Great. How can the data help support protections for opioid prescribing through telehealth at the state and federal levels?
Education, education, education. You know, here I'm speaking to the converted, right? And that's fun because I think most of us all believe the same thing. But when I speak at national conventions or international conventions about this, not everybody does. That's to sleep doctors. And then if I talk to primary care doctors or talk to neurologists, they certainly all don't believe the same thing. So I really just need to continue doing what I'm doing is just trying to educate doctors that low dose opioids are an effective and safe treatment long-term for RLS. And it's only just by reaching lots and lots of people who write prescriptions that this will change. Now, telehealth, currently, you do not need to see people face to face. At least at Mass General, I can do telehealth for opioid visits. I need to see people every 3 to 4 months. Those are Mass General and Massachusetts regulations, but I'm happy to do that. And I want to do that anyway, because I'm prescribing these medications, which can have significant side effects and have some risk for misuse and abuse. So I'm happy to meet with people every 4 months. But at this point, there's no problem seeing people over televisits, which is wonderful because I have people who are traveling from quite a distance. And for them, traveling into Boston is like a major, major ordeal. It's like going to the moon. And so being able to see people at home makes a big difference.
Okay. Could you please define well-controlled RLS?
I can't define it. You have to ask individuals, how
Yeah.
they would define it. But you saw that the average level of RLS severity was in the mild to moderate range. Maybe you mean well controlled for this research study that we're doing. And there it would be about the same thing, where RLS is not interfering with the ability to fall and stay asleep. For that clinical trial that we're doing, we don't want to try to treat RLS with suvorexant. We want to try to treat insomnia. So as long as the RLS is not what is interfering with falling and staying asleep, then that's what we consider well controlled for that clinical trial.
All right. Do you have something like a handout that I could show my doctor to convince him to prescribe an opioid for my RLS?
I think the RLS Foundation has a variety of resources that you can download and print and give to your doctor. I also just yesterday I was seeing patients, and there was a woman who said that she had switched pharmacies because the first pharmacy was really kind of being a little bit nasty about the opioids that she was picking up. And I said to her, number one, tell them to stick it. I may have even said that in more not such kind terms. And I told her to say to the pharmacist, look, my doctor wrote this prescription. He thinks it's of value. If you have any difficulties or problems with that, please call him, but at least treat me professionally. And the third thing I said was print out something about the efficacy of opioids for RLS and give it to the pharmacist. And you should do the same thing for your doctors and say to them, here's something that can help you learn about current treatment of RLS. Because for many doctors, they think current treatment are dopamine agonists. They think that's first line appropriate treatment. And they should learn that that is no longer true. And they're probably not hearing about that in continuing medical education courses. I try to reach as many as I can through such courses, but obviously I'm only one voice. Print something out, give it to them.
So the most important document that we have that all members receive is our latest medical bulletin, and it outlines all of the first line and second line treatments for RLS. So if you're a member, you can always download it in the member portal. If you're not a member, become a member and we'll send, it comes in your new member packet. And most people bring it to their doctor because it's includes dosages and maximum dosages and all the different medications that are effective.
And I do want to point out that we are developing a website called RLS Curbside. A curbside, just so that you know, is when one doctor pulls another doctor aside and says, you know, I've got this patient with XYZ, what do you think I should do? And the other doctor kind of gives them some guidance briefly. It's just a quick consultation, a couple minutes. And so we're developing a website, this RLS Curbside, that will be for doctors, doctor to doctor, where a doctor can go to the website, put in a little bit of information that doesn't have any private information like name, address, age, anything like that, and say, I've got this patient who has this RLS and I'm not sure what to do. And those of us who are in the expert community will be regularly going to this website and answering questions, because I get calls from docs all around the United States asking me about patients, and I thought it might be nice to have a resource on the web where not just me, but other RLS experts could address doctor to doctor type questions. So I imagine that we'll have that RLS curbside website up in the next 6 months. And so that will be also a place where you can say to your doctor, why don't you go to this website and you can just bring up my case there and you can get some advice about it. Free advice, doctor to doctor, about how to best manage more complicated, difficult cases of RLS. And I'm hoping that the RLS Foundation will partner with me in promoting this RLS curbside. It's obviously free, and it's kind of like what the RLS Foundation does for its members, where you members bring up questions and then it goes into night walkers and then different doctors respond to it. This is not for patients. This would be for doctors.
Wow, this is the first I've heard of this, John. This is fantastic.
I'm
A wonderful idea.
I'm bringing it up for the first time here. It's been percolating, and we're working with a website developer, and we've met, Jordana and I have met with the MGH. It was amazing. The people that we had to talk to at MGH about this to get approval for this, the chief legal counsel, chief privacy officer. We had more chiefs than you could imagine, and Jordana and me, and everybody seems to think it's a good idea. And we're excited that doctor to doctor, and then we're going to start promoting it at national meetings, national neurology, sleep, and GP meetings nationally.
Wonderful. Keep me posted. We'll
Will do.
definitely want to help with that.
Thanks, Zippy.
Okay. Are opioid prescriptions authorized by the FDA, or are they an off use?
These are all off-label for restless leg syndrome. There's no, in this country, no opioids that have FDA approval for restless leg syndrome. In Europe, extended release oxycodone does, but not here in the United States. So they're all off-label, but that doesn't, we prescribe medications all the time that are off-label. The most commonly prescribed sleeping medicine in the United States, trazodone, is not FDA approved for insomnia. So that's not an issue for doctors. They're accustomed to writing things off-label, but it is true none of them are FDA approved because no drug company at this point in time wants to develop a new opioid. I mean, it's not a popular class of medications at this point in time. Nevertheless, they obviously work very well at very low doses for RLS.
How can I find a willing physician or network into such a subgroup of medical practitioners?
That's a tough one, and I feel your pain. The RLS Foundation does have a list of medical providers who, in theory, are knowledgeable about restless leg syndrome and are up on the most current treatments, including opioids. But it's really tough. Most doctors now run from the idea of prescribing opioids. All they see or all they think about when they think about opioids is liability for them and side effects or danger for their patients. They don't understand the benefits of low dose opioids. But the RLS Foundation, I think, does have a list beyond the quality care centers, because there are only 10 quality care centers in the United States, and that doesn't cover a lot of territory.
Right, but the first thing you should do is look at the quality care centers, because that's your best bet in finding knowledgeable practitioners. Our list on the website is not totally up to date. We're working on it right now. We've been asking our members to send us recommendations of doctors that we could list on our website. And we've gotten a whole lot. I'd say we have probably a list of 200, but we're in the process of asking those doctors if we can list them on our site. So hang tight on that. We're working on it. Okay, I think that's about all the time we have for questions. And I just want to thank John very much for, let me move this out of the way, for his time. And I want to invite everyone else to our next webinar, which is Iron Infusions 101. It's going to be on Wednesday, June 15th, and it'll be up on our Get Involved tab under Education and Events for registration. Thanks so much for your time and have a great day.
Sleep well, everyone.